Okey, you all semua dah habis dah?
Dah habis, Doktor.
Ha?
Tadi
Belajar apa tadi dengan Ustaz?
Dr. Syed tak jadi.
Dia jadi pula.
Jadi, dia kata ada
Kenapa pula? Dia?
case dekat NICU.
Ha?
Dia kata dia tengah busy dekat NICU.
NSU. Siapa dia present lagi ni?
Saya, Doktor.
Siapa present? Present dah.
Saya present, Doktor. For the chief complaint, my patient Muhammad Daniel Hakimi, a 10 years old Malay boy, presented to emergency department of HTAA with the history of rapid bleeding for 1 day.
Boring lah. Kes malam siapa?
Kes malam Apika.
Apika. Kes ini rapid bleeding, dulu pun rapid bleeding. Tak ada rarity lalu. Apika, present.
Saya present.
Siapa kes malam? You orang tak ada kes lain ke? Pneumonia bronchiolitis dulu pun discussion case tu juga kan? Afika.
Okay. MPH ilmiah 7 years 4 months old Malay girl with underlying nephrotic syndrome was presented to accident and emergency department of Hospital Tengku Ampuan Afzan due to rapid bleeding for 1 day duration. Boleh teruskan, Doktor?
Terus.
It was taken from patient biological father.
Dia komplain apa?
She complained Ilmi Alicia, 16 years 4 months with underlying nephrotic syndrome, presented to HTA due to rapid bleeding for 1 day duration.
Okay,
Okay. This was taken from patient and her biological father. According to her father, prior to the admission, she was apparently well until 2 days prior to the admission, when she suddenly complained of having sudden onset of cough that occurred intermittently. The cough was productive with whitish putih, as well as chesty in nature. Otherwise, her father denied any facial congestion, cyanosis, obstructive vomiting, prolonged bout of cough, whooping cough, or barking cough. Besides, her father also complained that the child had generalized body swelling for 1 duration prior to the admission. Initially, she noticed to have periorbital swelling in the evening after coming back from school. Later on, she further complained to have facial puffiness, abdominal distension, sacral edema, and bilateral leg swelling. And based on her father, the swelling was in nature, non-tender, non-erythematous, and was not warm to touch. In addition, her father claimed that the child had lethargy, reduced inactivity, loss of appetite, and reduced oral intake over the period of illness. Otherwise, she denied any fever, rashes, runny nose, sore throat, abdominal pain, vomiting, loose stool, dizziness, or any headache. Furthermore, She also had increase in frequency of urination, which occurred about 5 times per day, as well as reduce in urine output or oligouria noted. Otherwise, the child did not any dysuria, gross hematuria, proteurine, or back pain. According to her father, in the morning prior to the admission, the patient had urine albumin 2+, but denied any gross hematuria. Later on, in the middle of the night prior to the presentation, her father claimed that the child had sudden onset of rapid breathing, which occurred during sleeping and was noticed by her mother. According to him, the child had no cyanosis, no facial congestion, or noisy breathing. He was unsure if the child had any recession at that time, and the child was immediately brought to emergency department of HDAA to seek for medical attention.
Continue.
And
Continue.
upon further questioning, her father revealed that this is not her first time being admitted to the hospital. The first admission was in February 2016, when the child was 2 years, 4 months old. She was admitted to HDAA due to newly diagnosed nephrotic syndrome, which she was presented with fever and generalized body swelling at that time. Her father stated that the child was induced with tablet prednisolone for 60 milligram per millisquare and achieved remission after day 8 of induction. Since then, she had infrequent relapse of nephrotic syndrome, which the last one was in October 2018, that leads to second admission to HDAA. Her father claimed that she was 5 years old at that time and also had similar presentation. And the child was diagnosed with relapsed nephrotic syndrome as well as tonsillitis with pneumonia during that second admission. And according to her father, the child was on tablet prednisolone but defaulted treatment for more than 1 year. The child also was not on any restriction of fluid at home, but taking diet with less salt. Apart from that, the child had also history of frequent nebulization since she was 1 year old that required almost yearly. It was triggered by upper respiratory tract infection as well as cold-induced. For asthma profile, she had no interval symptoms but had eczema as well as early morning sneezing and habitual rubbing of nose that implied allergic rhinitis. According to her father, there was positive family history of asthma noted in the family, which her sister, 16 years old, had asthma and also had frequent nebulization. Otherwise, her father denied any family history of nephrotic syndrome or kidney disease run in the family. There was also no sick contact at home and unsure of any sick contact at school. There was no recent history of traveling or going to crowded place, as well as no history of insect sting, food allergy, or drug allergy noted by her father.
Continue.
For systemic review, the child had generalized body swelling.
Dah HOPI dah ada dah, kenapa nak letak nak sebut semula?
Tak payah. Sorry, doktor. For past medical and surgical history, dah sebut dalam HOPI juga. But there was also no history of any surgical operation. Birth history, antenatal history, it was uneventful, which her mother did not suffer from any maternal problems like gestational diabetes mellitus or pregnancy-induced hypertension. There was no abnormality noted during ultrasound checkup. For intrapartum history, she was born at HDAA. She was born at Hospital Sultan Haji Ahmad Shah, Temerloh. She was delivered full term of gestation, which her father was unsure of how many weeks, via spontaneous vaginal delivery. Her birth weight was 3.59 kilogram with any birth complication. For postnatal history, there was no postnatal complication and she was not admitted to any ward after delivery. There was history of neonatal jaundice for 3 days, which did not require any hospital admission. The child was not on phototherapy and it was resolved without any complication. For nutritional history, she was exclusively breastfed up until 2 years, 2 months old and never had any formula milk. She started weaning at 6 months old by eating nestum and porridge. Currently, she consumes adult foods, which she ate about 3 to 4 times per day, consists of rice, fish, chicken, meat, vegetables, especially carrot, fruits, and seafood. For breakfast, she ate 1 bowl of cereal and 1 cup of Milo. For recess, her father was unsure what she usually ate, but for lunch and dinner, she ate 1 to 2 scoops of rice with chicken or fish and green vegetables. She did not eat snacks or fast foods. The child was on less salt diet, but not on restriction of fluid. Her father complained that the child was picky eater sometimes. Otherwise, there was no history of allergy towards foods or cow's milk. For growth and developmental history, the child has achieved the development milestone appropriate for her age, which is 7 years, 4 months old. She is studying at Sekolah Kebangsaan Bunut Rendang, Indrapura at Standard 2. The child is active at school, playing netball as well as had good performance at school, in which she got Anugerah Cemerlang when she was in Standard 1. Her favorite subject is English. There was occasional absence at school, which was about 4 to 5 times yearly. She is able to read, write, singing, and dancing. Her activity daily life is fully independent. For drug and allergy history, she was prescribed with tablet prednisone medication, but defaulted treatment for more than 1 year. Otherwise, her father denied giving her any herbal medication or supplements. There was no known drugs or food allergy. For immunization history, her father claimed that she was vaccinated up to the schedule according to the immunization schedule by MOH of Malaysia and has never skipped any dosage of vaccine. She also did not take additional vaccine. According to her father, there was no previous complication towards immunization, such as fever or rash after each vaccination. So for family history, the child is third out of 4 siblings. She has elder sister who is 16 years old and asthmatic. The second one is her older brother who is 12 years old with no known medical illness. The youngest one is her younger brother who is 1 year, 6 months old with no known medical illness. There was no consanguinity marriage. Her father is 40 years old, working as farm supervisor, smoker, and had underlying medical illness, which are hypertension and hypercholesterolemia, which was diagnosed in early this year, which was diagnosed in 2020. He was on medication, prescribed, but claimed to skip treatment, sometimes due to taking care of the child. Her mother is 40 years old, housewife, and had no known medical illness. Otherwise, there was no family history of nephrotic syndrome, kidney disease, or malignancy runs in the family. For social history, the child and her family live in a single-story house at Taman Indra Sempurna. The house is equipped with all basic amenities, good clean water, and electrical supply. Her father is a farm supervisor, while her mother is a housewife. Their total monthly income is about RM2,000 per month. The nearest clinic is Klinik Kesihatan Kurnia, which is about 10 kilometers from the house. The child leads an active lifestyle prior to onset of illness.
Musawah ada question.
Ada. I want to ask, does the patient have signs of heart failure such as paroxysmal nocturnal dyspnea, orthopnea, or chest pain?
There is no orthopnea, paroxysmal dyspnea, or chest pain.
Fikah?
I want to ask regarding the swelling. Is it mentioned the location of the swelling?
Pardon? The
Afina?
Is there any abdominal pain?
abdominal pain. There is abdominal, but there is abdominal distension.
Afina?
Because I want to access the.
Okay. I would like to ask, you've mentioned that the patient had infrequent relapse previously. So far, how many in total? How many relapse did she previously had?
Total of relapse occur 4 times. The first relapse was on October 2015. The second relapse was on May 2016. The third relapse was on April 2017, and the last relapse was on October 2018.
One no?
I would like to ask if there is any sore throat she's having or hemoptysis.
There is no sore throat or hemoptysis.
Adib.
May I ask the patient whether she had any previous history of skin lesion, suggestive of impetigo?
No. There was no history of skin infection.
I want to ask, did the patients have any recent weight gain noticed by the father?
So again, there is no recent weight gain, but there was loss of appetite and reduced oral intake.
No, Edina?
I want to ask, does this patient have any sign and symptoms of that evidence of she maybe might having infection other than cough or sore throat or sinusitis? Maybe fever?
There was no fever or any ears pain or eyes or ears discharge that can indicate infection.
Okay, thank you.
Atika?
Is it mentioned that the sputum is frothy as well?
No, there was a whitish sputum mentioned by the father.
Iza?
I would like to ask regarding the complication of nephrotic syndrome, such as is there any possibility that the patient has increase in thrombotic tendency, such as numbness in the legs?
No, no numbness, weakness, or any.
Putri?
I would like to ask if the patient has any myalgia or arthralgia, signs of autoimmune disorders.
There was no arthralgia, myalgia, or stiffness noted.
Zakwan?
Okay, I would like to ask, in this case, our case, in the history part, the student is have clock deeply into the nephrotic syndrome, but we know that this patient have the underlying, right? So my inquiries is that decision chief complaint is the rapid bleeding, right? So I would like to ask whether why did we did not dig into deeper in the rapid bleeding, which is I assume it may be asthma in this case, which is our main concern. It's nephrotic syndrome. Yeah, it can go below sikit. So to inquiry saya tu.
Well, it could be due to breathlessness of pleural effusion due to nephrotic syndrome.
Yes, complication of one of the complication of nephrotic syndrome can be the short rapid breathing.
So you
Because
think from your history, do you think is apa tu hypoactive airway or pleural effusion?
hyperactive airway.
Hypoactive airway itu asthma lah, asthma like hypoactive airway or nephrotic syndrome. Which one from your history?
Nephrotic syndrome, because there is
You mean the cause of shortness of breath is nephrotic syndrome from your from your history?
yes, because there is generalized body swelling.
That's the cause of shortness of breath. You don't think this due to because the child got previously recurrent shortness of breath due to hyperactive airway or asthma? Some colleagues think is due to asthma. Some colleagues think due to because of nephrotic syndrome. Which are more common?
The asthma.
Huh?
Because
or perhaps unluckily he got both.
I believe it can be due to asthma because there was no signs of PND and also autopnea suggestive of pleural effusion.
Pleural effusion, PND, autopnea due to heart failure. It's not due to pleural effusion. How many pleural effusion do you see got shortness of breath? You tengok adult kan? You tengok adult tak? How many pleural effusion? How many apa tu? You tengok how many case, how bad the pleural effusion tu before develop shortness of breath. From history, how you want to exclude either which one?
The exacerbation occur, is it occur at night and worsen at night or early in the morning? To exclude asthma.
You mean that early in the morning pleural effusion tak boleh berlaku?
But usually in asthma, the symptom you can see it's worsen, especially during at night and in the morning. But pleural effusion, the pattern is not that. Yeah, it's not at night and in the morning.
Yeah,
it can occur anytime.
Night is only half of the day. Unluckily, they happen the most severe at the night. 50% chance of having at night because night is half of the day.
I think for asthma, we need to first rule out whether there is potential triggers that.
Is there any triggers or not on history?
Yes.
No
triggers, doctor. But
ada trigger dalam cakap triggered by upper respiratory tract infection as well as cold induced.
Mana presenter ni? Orang lain boleh perasan, you tak boleh perasan.
Because the reason why the child has frequent nebulization.
The one patient have possibly anybody diagnosed asthma in the child before or not? Any doctor diagnosed child asthma before?
Asthma. No.
Tak ada. Umuran ni berapa? Umuran ni berapa dah?
7 years.
7 years with frequent nebulization. Nobody diagnosed asthma. None of doktor yang tengok budak tu diagnosed asthma or parent tak mention anak dia kena lelah. Do the parent told you that anak dia ada asthma?
The father only told that she had eczema as well as early morning sneezing and habitual rubbing of nose. Allergic rhinitis.
Father beritahu tak anak dia allergic rhinitis? Ada?
Yes.
Tapi why anak dia kena frequent nebulization, father tak beritahu?
About the upper respiratory tract infection.
Pardon?
Upper respiratory tract infection and
you think upper respiratory infection cause nebulization ke? If you have upper, berapa ramai you pernah ada semua tak? Bila kena semua ada nebulize tak? So you artikah kalau you ada upper respiratory, you going to be nebulized.
Sorry, doctor, my internet connection lost just now.
Afrika. You rasa kalau you kena sesemua, you will be nebulized.
No.
Why you agree with the parent, with the father? Dia start nebulization umur berapa?
1 year old.
Last nebulization bila? Sebelum dia masuk ward ni?
Last nebulization. Tak mention, doktor.
Tak mention ke atau you tak cari? Dia patient you kelak ke you tak kelak?
Senior punya case, doktor.
Itulah, betul ada suka ni. Ada dia tak tahu nak discuss, tak boleh nak discuss history. Tak boleh discuss history lah. There's something wrong with history in this case. You are unable to decide is it a hyperactive airway or is it a pleural effusion. On history, tak boleh figure out. So, Musawa, how to differentiate?
In asthma, they got no complaint of swelling, no generalized body swelling. So in this case, probably.
Do you know? You all tahu kan? One of the trigger of relapse is the apa? One of the trigger of relapse nephrotic is what?
Infection.
Infection. What kind of infection?
Throat infection and respiratory infection. Pneumonia pun boleh. Dengan
what is the main infection can cause relapse in nephrotic?
Acute respiratory infection and URTI.
URTI or UTI. URTI also can be a trigger for
asthma
attack. Okay, I agree that. So Nick, you think this child is having asthmatic attack or pleural effusion?
I am more towards the pleural effusion.
Why?
Because of the there is complaint of generalized body swelling. There is a periorbital swelling, and which suggests, and also facial puffiness and abdominal distension, as well as sacral edema, which suggests third space fluid loss.
How many Dato? Alfikah, what do you think? Afikah, sorry, Afikah Atirah. Lama pasal Afikah, kenapa you all ni? Afikah, Atikah semua dia dekat dia. Afikah Atirah.
I think the diagnosis is more towards nephrotic syndrome because the father also mentioned that he did the urine dipstick test, right? And it is 2+. There is proteinuria as well.
Afrina?
I agree with Afika as well because of the presentation, the way of presentation, and then the
One no.
I also agree with Musawa and Afika because of the presentation patient comes with.
I think it can be due to pleural effusion. I think it's more likely due to pleural effusion.
No, I
agree with them because most of the symptoms towards nephrotic syndrome.
No, Idina?
Me too, because pleural effusion is also known as one of complication for nephrotic syndrome.
Atika?
I also have the same opinion.
Iza?
I also think it's because of the nephrotic syndrome.
Putri?
Yeah, I think it's due to the pleural effusion.
Zakwan?
I have different opinion from the others.
Why you have different opinion?
Because it may be true that others are saying that this patient have the signs symptoms of pleural effusion. However, we cannot deny that this patient have the signs of asthmatic attack too, because this patient have history of frequent nebulization and the triggers of asthmatic attack and the atopy. So I would like to remain with my opinion. This patient may have asthmatic attack too.
Which further history you want to know?
From this patient, I would like to know if this patient have the wheezing, and I would if the attack is it is the first time or it has been several times before.
Afika?
Yes, there is no meaning attack, asthmatic attack. Do you mean the asthmatic attack? The point?
Tak dengar.
Yes.
There is no asthmatic attack before, but the father only mentioned that the history of frequent nebulization, eczema, early morning sneezing.
Don't you think that the check of eczema, allergic rhinitis show that perhaps you're dealing with child with asthmatic? Frequent nebulization.
Yes, and there is also positive family history of asthma.
How many cases of nephrotic syndrome you see have pleural effusion? How many cases? Do you think the pleural effusion will come very early or quite late? Do you think pleural effusion will come with severe edema or just moderate edema?
Severe edema, doctor.
Do you think that how low albumin they should be before they can have pleural effusion? Do you think pleural effusion is a common presentation of nephrotic syndrome? Huh?
No, facial swelling is
Buka internet. Semua buka. Apa tu pleural effusion nephrotic syndrome? Apa insiden dia?
It says that pleural effusion occur only in severe hypoalbuminemia.
Pardon? How many plus of the albumin there? How many plus? In
It was
urine.
2 plus.
You think that kalau 2 plus the child develop pleural effusion dah? How much plus you expected your albumin to become pleural effusion? 2 plus, 3 plus, 4 plus? You think 2 plus albumin in the urine adequate to the child for the child to develop pleural effusion? Nick, how bad is it the edema from history? Mild, moderate, or severe?
I think severe, doctor.
Why you think severe?
Because it has goes up until the facial area as well as it is coupled with the breathlessness.
Which one counter? Sekarang forget about breathlessness.
Okay.
We are unable to decide is it from the hyperactive area or pleural effusion.
Okay.
My question to you, edema. Edema is what you look. Pleural effusion is a part of nephrotic, but it's not an edema. Faham tak? So how bad the edema is?
I think it is severe because it has goes up until the facial area.
Oh, facial come first kan? How can you say goes up until facial?
Plus it has abdominal distension.
Really?
So
is it because abdominal distension or cause shortness of breath?
Because no, I think not because of the abdominal.
You don't think abdominal distension can cause shortness of breath?
It can be, but it can such as in case of ascites.
Severe ascites doesn't cause severe shortness of breath.
Yeah, I think so. Yes.
Can the child still walk?
If there is ascites, I think.
The child can still walk or not? Can the child still mobilize?
Yes, doctor.
Huh?
The child was alert and conscious and had normal activity and movement.
Wah, aktif, berlari semua ya. With severe edema. Boleh ke?
Tak boleh. Kalau macam tu.
Atikah, what do you think?
I think
What
so,
are the edema you
if-
want to look at to know it's severe or not severe? They can help you. The child is edema, so they can help you to tell you the severe, how severe edema is. What are the edema you want to look at?
Doctor?
There are what other edema at the part of the body you want to look at that can help you to tell you perhaps the edema is severe.
sacral.
Huh? Other than sacral?
Scrotal, but it's already mentioned.
Pardon?
Scrotal, but Afika already mentioned there is scrotal edema.
Then she got scrotal edema, is it? So mild, moderate, or severe? Check and walk around, lari-lari, active.
Probably moderate, doctor, because the symptoms, I think it's the symptoms affect her.
If the child got pleural effusion, you think the child can walk lari-lari around?
But the patient,
she will become less active.
Huh? The patient
the patient has lethargy, right?
Lethargy, kat physical examination dia dalam tu Adikah kata patient is active walking around.
Patient is lethargy, reduced in activity in the physical examination.
Huh?
In history, the patient is lethargy and reduced in activity.
In physical examination?
Physical examination, the child was alert and conscious and had normal activity and movement.
Tak pelik. Mana yang betul ni? Apa yang nak?
Yes. Regarding the edema or?
Regarding everything is it? Itu di history betul ke? Physical examination and history not congruous.
I think it should mention physical examination was done when, because I guess if we're thinking of asthma, then perhaps they did nebulization and then the child is okay.
If the child got pleural effusion, what the child need nebulization?
Or if we're thinking of asthma, but if just now if we're thinking of asthma, but if we're thinking of pleural effusion, then I guess it doesn't make sense.
You yourself say it doesn't make sense.
Yes.
If pleural effusion, what the treatment should be? One more. How bad is it, the shortness of breath?
It's not severe, I think, but
The mild, moderate, and severe. Tell us what your opinion.
Moderate.
Why you think it's moderate?
Because she's presenting with generalized edema, and she also have
Generalized edema tell you the severity of shortness of breath. tell me from where you take it general stigma to tell you the severity of shortness of breath. So the child having shortness of breath. What you think, mild, moderate, or severe?
Can I say it's severe, doctor? Because it's occur when sleeping.
Huh?
The rapid breathing is also occurs during sleeping. So according to the PITS protocol, if the breathless occur during this at rest, it's considered as severe.
Breathless or tachypnea? Yes.
Breathless.
Ah, dia tachypnea. Tell me how you assess if mild, apa sign symptom dia?
If it's
Baca
mild,
ha. Apa mild?
the parameters, isn't it?
Apa parameters?
The parameters we assess the breathless. Is it when in mild when walking?
Lagi?
Talks patient can talk in sentence.
Lagi?
Still can talk in sentence, not only word or phrase.
Lagi?
The alertness may be agitated. Respiratory rate normal to mild. There is no use of accessory muscle. Wheezing is present in all severity. SpO2 more than 95%. The pulse rate is normal, and PFR more than 80%.
Moderate?
Moderate, breathless when walking as well, but there is feeding difficulties, talks in phrases, alertness, agitated, respiratory rate increased, there is use of accessory muscle, wheezing present, SpO2 92 to 95%, pulse rate increase, PFR 60 to 80%.
Severe?
Severe, the breathlessness occur even at rest, and we can notice the child even stop feeding. The child can only talk in words. The alertness is agitated. Respiratory rate markedly increased. In moderate increase, but in severe markedly increased. There is use of accessory muscle, wheezing present, SpO2 less than 92%, because it's not better even when we oxygenate the child. The pulse rate increased, PFR less than 60%.
So, Adit, what the patient have, what the patient has not?
Sorry, doctor, what does the patient have? Apa?
Patient has not. Dia dengar kan assessment, what the patient have not.
Patient does not have wheezing.
Tak sistematik lalu pemikiran you. Siapa present tadi?
Ya,
Ilana, siapa?
Afrika, not Afrika.
You present tadi ya lah, you present severity tu.
Oh, Afrika.
Siapa present Afrika Atira, mana dia? Kenapa? You present tadi Afrika Atira. Siapa present mild, moderate, severe tadi? You present semula kepada Adib tu. Masih tak faham lagi.
Ni Dr. Afrika Atira.
Present semula ke Adib. Dia faham apa tu mild atau moderate atau severe. Present semula. Mild tu apa? Dia lost somewhere tu.
Okay. Adik, can you hear me clearly?
Dengar tu. Tanya supaya dia dengar. Tak boleh dengar.
So
Okey
from
lah. Dengar lah tu.
So
if mild apa?
So the parameters, I think we should kalau mild tu tengok daripada history pun boleh tahu. Breathlessness, mild when walking, moderate when walking, but the child has difficulty in feeding, severe even at rest. also there is episodes of
You tak
restlessness.
cakap macam
And
tu.
the
You
child,
kena cakap,
it can be not.
dengar sini Atika. Kalau you nak ingat, you cakap mild sampai habis ke bawah dulu. Moderate sampai habis ke bawah dulu. Severe sampai habis ke bawah dulu. Kalau you melintang, you tak akan ingat. You kena visualize dulu apa tu mild, visualize tu apa tu moderate, visualize tu apa tu severe.
Okay,
You
for
go
mild,
melintang,
the
memang
restlessness.
you tak akan ingat. Benda ni you nak you tak boleh hafal tapi you visualize.
Okay, so for mild. Okay,
Mula cakap
for
pada adik.
mild, the
You
restlessness
cakap pada adik.
occur during walking.
Mula gini, you cakap pada adik. Boring lah nak explain sekali lagi. Yelah, kena explain sekali lagi. Dia tak dengar tadi. You kena explain sekali lagi. Boringnya lah. Explain sekali lagi. Mild apa? Cakap lah.
Okay, mild, the restlessness occur. Cakap apa?
Yelah apa lah tadi, downwards lah.
Explain. Okay, for mild, the restlessness occur during walking. The child can talk in sentences. The alertness may be agitated, may not be agitated. Respiratory rate, it can be normal to mildly increase. There is no use of accessory muscle like wheezing present in all case, includes mild. SpO2 more than 95%. It means that when we oxygenated the child, it improved. Pulse rate normal. PFR more than 80%. In moderate, the breathlessness occur during walking, but there is difficulty in feeding. It can the child can talk in phrases. Alertness agitated, respiratory rate increased. There is use of accessory muscle. Wheezing present. SpO2 92 to 95%. Pulse rate increased. In mild, normal, so in moderate increase. PFR 60 to 80%. Severe, the symptoms, the breathlessness symptoms occur even at rest, and we can see the child even stop feeding because of the breathlessness. The child can only talk in words. Alertness agitated. Respiratory rate markedly increased. There is use of accessory muscle. Wheezing, there is presence of wheezing. SpO2 not improved, not better with oxygenation less than 92%. And the pulse rate increased. PFR less than 60%.
So, adik, what patient have or patient have not?
Patient is tachypneic. Patient does not have breathlessness. Patient can talk in sentences. Patient is alert. She's not agitated at all. There's no use of accessory muscle.
Ada ke Afikah mention not using accessory muscle?
Dalam physical examination tak ada.
Kita tak pergi physical examination. Have you done physical examination?
No. So dalam history, patient's father cakap yang patient breathe using abdomen as well.
Using abdominal breathing? There was accessory muscle tak?
Ada.
Apa lagi?
And then there's no wheezing.
Dia mention ke wheezing, there's wheezing, no wheezing?
Dia cakap tak ada sound.
Tak ada sound. Tak ada sound tu wheezing ke? Sound tu banyak, cakap sound juga. Did the presenter just now present there is a wheezing, there's no wheezing? Ada ke?
Tak ada. Tak ada.
So is there wheezing or there's no wheezing?
Dia just cakap there's no noisy breathing.
Noisy breathing. Stridor noisy breathing. So that imply everything, is it? Nosy breathing termasuk wheezing sekali. How specific, how. Okay, ada apa lagi? Tapi this one, you tak percaya is due to because of the asthma. So nosy breathing is not relevant if you think it's due to pleural effusion. Unless you're thinking this one is due to by the asthma. So any other things?
Patient has reduced feeding, but it's not mentioned it's due to the shortness of breath, but it's mentioned due to the coughing. The
Reduced feeding due to coughing. I mean that
uh,
patient coughing 3 hours, 4 hours continuously.
so macam
Sampai tak boleh nak minum.
No, the explanation about the loss of appetite and also reduced oral intake was mentioned for the generalized body swelling, coughing, and also the edema. The history about the shortness of breath was very short and not mention anything about
Don't you think funny or not this case? She complained apa?
Shortness of breath.
How much she touched about shortness of breath in this case?
Very little.
Very little. Don't you think funny? You think that all case with relapsed nephrotic syndrome we're going to admit? But all case of shortness of breath we're going to admit or not?
No.
Huh? So what do you think the shortness of breath, mild, moderate or severe?
Mild.
Why you think it's mild?
Patient is not breathless at all, only had increase in respiratory rate. She's not
How you know a
agitated
patient not breathless?
because it does not mention. The father only mentioned, the father only said that
You think the father know the
definitely-
patient breathless, not breathless?
I am not sure.
Sure. Idina,
Yes, doctor.
What do you think? Mild, moderate or severe?
From the history, because of the history of regarding the rapid breathing is kind of secret. So we only know that the patient has shortness of breath at rest since the mother noticed it happened during sleeping. But then you're not sure whether the shortness of breath occur during walking or talking.
Okay, lagi?
For now, I think it's severe. It's severe shortness.
That's all. What about the other parameter?
Can we ask about the respiratory rate and the SpO2?
If you, where you can get information about SpO2?
From the physical exam.
Where will the first SpO2 will be done?
By bedside.
Where is it will be done before the child being admitted?
I'm not so sure, doctor. I think when you take blood pressure.
Blood pressure pula. Atikah, what do you think? Where will people take SpO2? When the patient brought to the
I think at the emergency department.
So is there any data about the SPO2 at emergency department?
I'm not sure, doctor, but in the physical examination on the day of admission, the SPO2 was 100% under room air on the day of admission. I'm not sure whether
The day of admission, the chair be nebulized or not?
Doctor, in my opinion, Doctor, we cannot determine the severity of this patient's breathlessness because the student did not ask further into the breathlessness.
Boleh jadi consultant. But there are some indicator. The child is weak and lethargy, but we're not sure the child can speak in the full sentences or not. If the child can, when the child came in, the child walking ke, or the child been brought in by the wheelchair ke whatsoever. The child is sinus or not sinus was not mentioned. I was not sure. Accessory muscle usage, accessory muscle usage only one. Accessory muscle usage is abdominal movement only, but the child is edema. What you want to look is the intercostal, subcostal, and costal muscle. Okay, physical examination is not valid because most of the time the physical examination was done in the ward or treatment was given. But we want to know what's happened during that time. Saturation also usually you can ask what the saturation. Parents usually notice what saturation in the E&E and what was treatment were given kan E&E when patient was having a shortness of breath. Apa lagi? But if the child got mild shortness of breath, would the child be admitted? Cerita balik shortness of breath budak tadi. Afika.
shortness of breath. So in the middle of the night prior to the presentation, her father claimed that the child had sudden onset of rapid breathing, which occurred during sleeping and was noticed by her mother. And according to him, the child had no cyanosis, facial congestion, or noisy breathing. He was unsure if the child had any recession at that time, and the child was immediately brought to the emergency department.
Tu je lah.
Tu je.
Physical examination.
Physical examination. So for general examination, the child was alert and conscious and had normal activity and movement with Glasgow Coma scale of 15/15. She had a normal body build appropriate for her age. She was comfortably lying in supine position on her bed, supported with one pillow. She was pink with no jaundice, pallor, or cyanosis. She was not in pain or septic looking with no sign of respiratory distress. There was no dysmorphic features or neurocutaneous stigmata noted. There was a branula intact at her right dorsum hand with no active infusion, as well as restriction of weight, cup, and nephrotic chart noted on the table. On peripheral examination, there was no finger clubbing, peripheral cyanosis, pallor, or palmar erythema noted. The hands were warm to touch with capillary refill time less than 2 seconds. The skin to the gore was normal. There was no stigmata of infective endocarditis such as sphincter hemorrhage, ocular nodes, or granulation. There was also no leukonychia, coilonia, or rashes noted. The child was tachycardic, with pulse rate of 160 beats per minute, regular rhythm with good volume. On examination of arms, there was no rashes, bruises, or scratching marks noted. BCG scar was noted on left deltoid muscle. On examination of the head size and shape was normal. There was no head swelling or signs of head injury. For face, there was periorbital swelling and facial puffiness noted. That was not tender, warm, or erythematous. For eyes, there was no conjunctival pallor or scleral jaundice. Both ears revealed earwax with no sign of infection or ear discharge. The oral hygiene was good. The lips was moist and no coated tongue noted. The throat was not injected. Tonsils were not enlarged, and there was no central cyanosis. On neck examination, there was eczema noted, but no cervical lymphadenopathy, abnormal swelling, abnormal or neck stiffness noted. On leg examination, there was bilateral pitting leg edema up till mid-shin that was not tender, warm, or erythematous. There was no calf tenderness noted. On back examination, there was sacral edema but no spina bifida. For anthropometric measurement, the height was 120 centimeter, weight 26.8 kilogram, and the BMI was 18.6 centimeter per kilogram square. So for vital sign on the day of admission, the temperature was 37.0 degrees Celsius, pulse rate was 160, blood pressure 164/112 millimeter mercury, respiratory rate 45 breaths per minute, SpO2 was 100% under room air, and the perfusion was less than 2 seconds. So for abdominal examination, on inspection, the abdomen was symmetry, mildly distended, and moved.
First, chief complaint dia adalah shortness of breath.
Yes, sorry, doctor. So for respiratory examination, on inspection, the chest moved symmetrically with respiration. There was marked subcostal recession, but no chest wall deformities or surgical scars. On palpation, the trachea was centrally located. The apex beat was palpable at 5th left intercostal space below the mid-clavicular line. The chest expansion was symmetrical and equal bilaterally. The vocal parameters was normal. On percussion, all lung zones were resonant bilaterally. On auscultation, there was reduced in air entry bilaterally with normal vesicular breath found. There was generalized bronchi and mild crepitation. Noted, the vocal resonance was normal. For cardiovascular examination, the pulse rate was high.
Habis. Nick, so what do you think of the shortness of breath? Pleural effusion ke or hyperactive airway?
I think because of
you have listened the history, you listen physical examination. What do you
think is pleural effusion because there is a crepitation.
Crepitation pleural effusion. Aduh, teruknya lah.
Itu pleural edema.
Afrina?
Bronchi, doctor, lower
What the finding of pleural effusion?
Stony dullness.
You see, no point to go further dengan you all. You see, because you all tak ada basic knowledge. Tell me what to discuss if you don't know what is the finding of pleural effusion. No point. I don't want to go further. Because that is the basic thing. We give the lecture to you already. What the finding of pleural effusion, tak dapat tahu. Basic, basic. You don't know what the finding of pleural effusion. Basic thing. You telling me what I'm going to teach you? Because it's already been taught. So weak. Well, no. What do you think?
It does not redirect to pleural effusion.
No apa?
The physical examination does not suggestive of pleural effusion.
If you efficient, what the finding you expected to find?
Stony dullness on percussion.
For stony dullness apa lagi you want to look? Yang skatik, apa finding dia? Dia ni kan tak payah hafal tau.
Reduce breath sound, doktor.
Kenapa reduce breath sound? Pleural effusion.
Doctor, from what I read, if there is a pleural effusion, we will find dullness to percussion, decreased theta parameters, and asymmetrical chest expansion with diminished or delayed expansion on the side of the effusion.
Lagi what more? Breath sound?
What? Sorry?
Air entry?
Air entry, I would say it's decrease.
Decrease of very little air entry or no air entry.
Decrease air entry. It will be decreased air entry.
Water can transmit sound ke? Tapi you can check. Will be a mark reduce, or they can sometimes we know air entry heard. Because water is very bad. Second thing is a decrease in vocal
parameters.
So because they are decrease on nil, because the water is very bad. Then the other thing will be a dull on percussion.
Dull on percussion.
So you think the chair got this finding here?
No, the findings is more suggestive towards the respiratory problems, not because of the pleural effusion.
So, Adib, what do you think? What the cause of the shortness of breath?
I'm thinking the same like Anis Naziha. There's no sign of pleural effusion on physical examination. It is more likely due to hyperactive airway. Additionally, with the observation of intercostal recession. I mean subcostal recession, suggestive of asthma.
The child has got subcostal recession. What indicate to you about the shortness of breath?
It is due to asthma or hyperactive airway.
What indicate? What it tell you about the shortness of breath? The child got intercostal recession. Mild, moderate, or severe?
It is moderate. It is moderate or severe.
So the next thing is that Idina, tukar. No, Ain, the child asthmatic or not?
I would say, yeah, the probability is there for the asthmatic because the symptoms is suggest towards the asthma more than pleural effusion.
The symptom the child is having is the shortness of breath is due to because of the bronchospasm. But if the child is asthmatic or not?
Yes.
Why you think the child is asthmatic?
Because there is a risk for the there is a risk of the asthma, but
this asthma cerita lah. Why you think the child is asthma? Elaborate a little bit.
because the child is having nebulized and also has history of asthma and also has
history of asthma. We don't know. I
nebulized.
mean, nobody knows the child asthmatic. The father was not told the child asthmatic or not. But do you think the child is asthmatic or not?
In my opinion, yes, the child
Why
is
you
asthmatic.
think like that?
Because the symptoms is suggestive of the asthma.
Okay, what symptom you talking about?
I feel like the shortness of breath and also like the allergic rhinitis and also eczema and so on. So
Is it allergic rhinitis symptom of asthma?
No, it's like risk factor for asthma if I'm not mistaken. So like it's towards
What
asthma.
is the definition of asthma?
Asthma is hyperstimulations of the.
What definition of asthma? Anybody?
There is presence of IgE.
IgE. What definition of asthma?
Chronic airway inflammation.
Yeah,
leading
but
to
what
increased
the first line? Recurrent?
Reversible.
current episodes of wheezing, breathlessness, and coughing.
So the child got this recurrent episode or not?
Yes, frequent nebulization.
The child got frequent nebulization. You mean doctor suka yang nebulize? Do you think besok you all besok boleh apa respiratory infection you going to nebulize patient? If you do that, I don't know how why you all pass. Why we nebulize patient? Why we nebulize patient?
Secure the airway.
Reduce airway inflammation.
Why we nebulize the patient? Nebulizer is for treatment for what kind of problem?
For bronchodilate.
Why we bronchodilate?
Because there is.
Because in asthma there is bronchospasm.
We treat
edema.
We bronchodilate because the patient have bronchospasm. If your child not having bronchospasm, why you want to bronchodilate? For edema treatment dia bronchonebulizer. Edema treatment dia apa?
Diuretic.
Diuretic. Kalau bronchospasm treatment dia bronchodilator. So why is it the doctor given the child nebulizer? Because the child is having having bronchospasm. So why you think the child this child is asthmatic? No,
Sorry, what is?
Why you think the child is asthmatic? From
Because
history.
Because she has infrequent nebulization.
Infrequent.
Frequent nebulize.
Which
indicates that she has bronchospasm that suggests asthma.
The child got recurrent bronchospasm.
Yes.
And also the child got strong family history of
Asthma.
atopy.
Doctor,
And
just want to
family history
confirm.
of asthma. And also there is a history of trigger factor in this case. Apa tanya soalan?
Just want to confirm, can we like diagnose this patient as asthma only or acute exacerbations of asthma?
So what diagnosis in this case?
I would say asthma.
What the first diagnosis?
The first diagnosis that was mentioned.
Child is having apa? Acute exacerbation of bronchial asthma. And the second, the child also have
nephrotic syndrome.
We don't call nephrotic syndrome. We call what?
Relapse nephrotic syndrome.
Yes, relapse nephrotic syndrome. But I ask you the question. If you give me relapsed nephrotic syndrome, you don't give me diagnosis bronchial asthma, should I pass or fail you?
Fail.
If you give me a bronchial asthma, but you don't give me relapsed nephrotic syndrome, should I pass, should I fail you?
Pass.
Pass.
Why is it?
Because the main problem is the asthma itself, nephrotic.
Because the chief complaint in this case is what?
The rapid breathing.
Rapid breathing.
Yes, the chief complaint of this case is shortness of breath. Okay, ada letih dah. Itu letih. Any questions? Kalau kelas ni 37, boleh kita buat discussion macam ni?
Tak boleh. Susah.
Dan baru you faham kenapa I don't like it. Actually I like 5 orang. Biasa kalau 5 orang lagi banyak you belajar ke atau ni?
Lagi banyak.
Tapi you cepat tired. I rasa 40 minit you dah tired dah. Okay, sebab any questions?
Doctor, I have a question. Hello? Doctor, kalau how to know if pediatric patient, how to know whether he or she is presented with drowsy and confused?
Drowsy and confused. Confused ni.
Like how do we assess?
Confused. Okay, confused dia kalau dia pagi, dia tahu tak? You tanya dia sekarang pagi tak? Dia kata petang. Confused. Kalau drowsy ni, kalau you tanya dia apa tu pagi atau petang, dia tak boleh nak jawab. Dia tak tahu pagi atau petang. Itu drowsy. Confused kalau tanya dia pagi atau petang? Petang. When asked question of pagi. So that's what we call confused. Okay. Anything else? You all ni banyak confused or drowsy? Bobo. Okay, dah, sudah. Okay.
Thank you, Doctor.
Okay.
Doctor.
Okay, Doctor.